practice here in Fort Atkinson. Also have a satellite clinic in Lake Mills, and we also have an office in Watertown. I practice with two other partners. On the left is Greg Gralia, who's been with us for about 5 years now. And in the middle is Victor Soderstrom, who started practice at Rock River Foot and Ankle Clinic. He's been in practice a little over 20 years now, and I've been in practice with him for 15 years. All three of us have privileges here at Fort Atkinson Hospital. Our Fort Atkinson Clinic is just located down the street at 520 Handyside Lane in the medical campus behind the hospital. And we've been there for about a year and a half now. We moved from our old location on Whitewater Avenue about a year and a half ago. What I thought tonight we would cover is the four main problems that we see most commonly in our practice. As podiatrists, we treat foot and ankle conditions both medically and surgically. All the problems we see, probably the four most common are arthritis, bunions, hammer toes, and heel pain. So we'll break it down into those four categories. First of all, with arthritis, just basically going to split it into both conservative treatment and surgical corrections for arthritis. As far as conservative treatment goes, rest, ice and heat, NSAIDs, which are non-steroidal anti-inflammatory drugs, things like Motrin, Aleve, those type of products, steroid injections, shoes, and orthotics. Those are the basic treatment plan that we use for basically most different types of arthritic conditions of the foot and ankle. As far as shoes go, what you want to look for is a good, supportive, athletic or walking type of shoe. If you do have some problems with arthritis in your foot, this is going to give you the most stability, the most support, and the most comfort. You also may want to use some type of an insert in your shoe. We make custom-made orthotics or arch supports in our office. We do a casting, send it out to an outside lab, and have it custom-made specifically for your foot structure. That would be the one here on the left. This would be a custom-made device, full length. The one in the middle here is what we call a metatarsal or a sulcus length, which would go right underneath your toes or the crust of your toes. And then on the far right here is a metatarsal length device. As far as a surgical correction is concerned, there's basically four different types of procedures that can be done. And basically what I wanted to talk about tonight is arthritic conditions of the big toe joint or the first metatarsal phalangeal joint. That's probably the most common area that we see arthritis in the foot. You can get it in any joint of your foot, but most commonly we see it in the big toe joint. That's what that joint seems to take the most amount of stress in your foot, and that one tends to break down more quickly than other joints. That typically we'll see a condition of osteoarthritis that develops in the big toe joint. When we take an x-ray of the foot, basically what we'll be looking at is a number of different factors. But what we're looking at here, this is a lateral view. This is looking straight from the side of your foot, from either the outside or the inside. And this would be the big toe joint right here. And you can see some spurring right up here on the top. That's extra growth of bone up there. This is what we call an AP or a DP view. This means it's looking straight down from the top of the foot. And again, we're looking at this joint right here. This would be the tip of the big toe up here. These are the second, third, fourth, and fifth toes over here. And this is the big toe joint, the first metatarsal phalangeal joint. Everybody always asks, what are these two structures right here? And those are two little marble-shaped bones called sesamoids. And those sit within a groove underneath the big toe joint and allow your toe to flex up and down properly. What we're looking at here is if you look at this joint here and this joint here, these joints across here, you can see how they're nice and wide. You got this dark space through here and it's nice and even. And you can see here you have a little bit of space here, and then it gets really kind of white through here and closed down. That's showing us that the cartilage between there has worn away. And basically now it's bone on bone and it's grinding, which is what precedes the arthritic condition. This is just an intraoperative view of what an arthritic joint looks like. It should be nice and clean and white and glistening, and you can see we call this synovitis. Through this area here, it means the joint capsule is all thickened and scarred, and the bone gets this kind of yellowish tinge to it just from being worn over time, that it'll cause it to start to get those degenerative changes like that. The procedure that we're doing here is called resurfacing. I mentioned on the earlier slide that there's 4 different things that can be done. You can do a cleanup procedure where you just go in and clean the joint up. You can do a fusion procedure where you go in and actually remove what's left of the cartilage and actually fuse the joint with either screws or plates or some other type of fixation. Or now, just actually within the last couple years, it started actually with hips and bigger joints, hips and knees, but now we're doing them in the big toe joint, the first metatarsal phalangeal joint. We're doing resurfacing procedures. And this is a very nice procedure because it really speeds up the recovery afterwards, and it's much less invasive than doing a total joint replacement. There was a lot of total joint replacements done in the 70s and 80s on big toe joints, but they just found over time they just didn't hold up because of the biomechanics of the big toe joint, and they just didn't last as long as they have in the knee joint and the hip joint. So this is just kind of going through the procedures that are done. The bone is kind of reamed out. A post is put in down the medullary canal of the bone. This is, again, just scraping off the rest of the cartilage that's left on the bone. That's basically what the head of the bone looks like. On the right here is actually a trial or a sizer, kind of sizing up what size of cap that's going to be put on the joint. There it is in place, showing what size resurfacing is going to be done. And then this is the actual cap that's placed over the metatarsal head for the resurfacing of the joint. And then it's just tapped in place. It's just press fit, and that's what it looks like when it's done. And it's a titanium surface that allows for a nice smooth glide. Now you maintain the joint properties and the motion that you'd have in the joint. And that's what it looks like post-operatively on an X-ray. This is where the resurfacing was done there. That's the cap that would be on the metatarsal head. You can see how the joint is aligned there. Where it should be. All of the other debris and the arthritis has all been cleaned up. What's really nice about this procedure is when we do a fusion, we have to put the patient on crutches and in a cast, and it's usually for about 6 weeks to allow the joint to fuse, because basically we're trying to get 2 bones to form one, and they're not made to do that. They don't want to do that. They want to move, and we have to keep them from not moving. So when we do a fusion or an arthrodesis, the patient has to be off weight bearing and in a cast or some type of immobilization for about 6 weeks. When we do a resurfacing procedure, on average right now we're getting patients back into their shoe gear in about 3 weeks. For the first 3 weeks they're just in a surgical shoe like this, and we let them bear weight on their heel. So the recovery afterwards is dramatically less with the resurfacing. The next area that I wanted to go into is bunions. Bunions are probably one of the most common conditions that we see in the office. A bunion is actually a deformity of the first metatarsal phalangeal joint. A lot of people think it's actually a growth on the side of the foot, and it's really a structural deformity of the joint. And I'll show you that when we get into x-rays of bunions here in just a minute. As far as conservative treatment goes for bunions, again, non-steroidal anti-inflammatory drugs, your ibuprofen, Aleve, those type of products, because it is going to cause inflammation and swelling of the joint. As we talked about earlier, shoes, orthotics, and pads. As far as shoes go, when we're dealing with bunions, you're going to want a good supportive shoe, but you're going to want something that's made of maybe a little bit softer leather, gives you a little bit more room. What we're really looking for is something that has a lot of room in the toe box to accommodate that deformity. It keeps pressure off the big toe joint, which reduces pain and discomfort. Again, the orthotics that we talked about earlier, those will help support the foot, take some of the stress off the big toe joint, and allow the foot to function more correctly. Pads, in limited use, some padding can be used. Unfortunately, most of the time with bunion shields or other types of pads made for bunions, By the time you put something like that on, it actually takes up more room in your shoe and then puts more pressure over the bunion and can cause more of a problem. So usually that's only reserved for patients that are really in a situation where they can't have anything else done, where they're going to wear, they might be just in a nursing home situation in a slipper or some type of an orthopedic or a custom molded shoe where they have enough room to be able to put something like that on. Otherwise, in a regular walking shoe or most normal shoes that patients wear, it's not going to fit very well. It's very difficult to keep in place. As far as surgical corrections go for bunions, basically broken down into three categories here: bunionectomy, an osteotomy, and an arthrodesis. Bunionectomy is basically just taking the bump off and kind of cleaning it up. An osteotomy is actually cutting and repositioning the bone and realigning the joint. And an arthrodesis, just like we talked about earlier with the arthritis of the big toe joint, is actually fusing the joint. And here's just a typical preoperative x-ray on a potential bunion patient. And again, you can see what's happening here. They're getting this deviation of the first metatarsal phalangeal joint. Should be aligned straight, and you can see the adaptation that's taken place here in the joint itself. Now, clinically, this may not look that severe and may not be that far out of alignment, but sometimes when the joint becomes really adapted to the position like this, that can cause a lot of pain in the joint and with range of motion. And sometimes this whole first metatarsal will be splayed way out to the side over here, and the big toe will be actually crossing over the second toe. But it's actually not just a growth or extra bone right along this area here. It's actually a deviation of this whole metatarsal bone where it's splaying out to the side, and that's where you actually can see the bump clinically. If you look at this preoperatively on this patient, you can see how the first toe is abutting against the second toe. You can see the prominence here along the skin, and what's going on with the bunion deformity, how this is protruding out like this. And there's actually a tendon that inserts onto the big toe that comes from a muscle kind of angled over like this. And as this part of the metatarsal drifts out that way, that wants to pull the toe further back over that way. Just an intraoperative view of a bunionectomy, osteotomy procedure. Basically, we make the skin incision over the top of the joint like this. This is just a typical surgical blade that we're using. We use what's called an oscillating or a sagittal saw. It's actually a saw that vibrates back and forth very rapidly to cut through bone in a very precise manner with very delicate removal of bone. It can take literally 1 to 2 millimeters of bone at a time that can be cut or removed with this precise surgical saw. Apologize, this is a little blurry here, but this is actually showing where the bone has been cut. This would be the head of the bone here. You can see the big toe here, and it's actually shifted over or brought over, brought back from over to this area, back over this way, brought back over down towards the second toe here, and then where the bone's been cut, or placing a screw across there to hold the bone in position, in the new position that we want it to be in. This is, again, just showing another view, making another cut in the first metatarsal bone with the sagittal saw. Now, this is just another form of fixation. The other fixation I showed you was a screw that we use to fixate or hold the bone together where it's been cut. This is actually a little bone staple that we use. This is called an easy clip. And this is a little staple that goes in here and here. I'll show it on the post-operative x-rays, but it's held on this instrument, and once you release the instrument, it causes compression. It causes these arms, if you can imagine, it goes down like this and down like this. Looks like just like a regular staple, so it's kind of through here all the way through here. And when you release that, the legs kind of point in. I'm just actually here in this view, I'm tapping it in to get it flush with the bone. And that's clinically the post-operative incision with the sutures in the skin. And here's the post-operative x-ray. And now you can see the alignment of the toe, how straight it is here. That first cut was back here in the bone back here. That was slid over, realigned, and that's the screw that's in there that's holding the bone in that position there now. And then up here, A little wedge of bone was taken out of this bone here to bring the toe back over and straight. So actually this was a double osteotomy. An osteotomy was done here and an osteotomy was done here to correct the bunion at both of those levels. This one brought the first metatarsal head over, and this one brought the big toe back over into alignment. And you can see these are the arms on that staple now. When you take the handheld instrument off, it causes compression there to hold the bone tightly together. With this type of procedure, again, we allow patients to ambulate on their heel in a surgical shoe. They don't have to be in a cast or on crutches. And this is just a typical surgical shoe that we have them in, and that's usually for about 4 weeks. If you break a bone and it's not fixated, you don't have a screw or anything in it, and you let the bone heal naturally, it usually takes about 6 to 8 weeks for the bone to heal until you can bear full weight on it. But by using the screws and the staples with rigid internal fixation, we can speed up the healing time and get the bone to heal in approximately 4 weeks. Hammer toes are the next area. This is typically deformity of any one of the lesser toes, the second, third, fourth, or fifth. Most commonly, we see hammer toe deformities in the second toe. As far as conservative treatment goes, again, appropriate shoe gear and pads. Again, with shoes, you're going to want a shoe that has a high toe box, a lot extra depth for room for the toe to be able to be contracted and sit in there. Most of the time with a hammer toe, most patients are going to experience pain either on the top of the toe from rubbing against the top of the shoe, or they're going to have pain on the bottom of the ball of their foot from a retrograde force from the toe being contracted in the position that it's in. So typically with shoes, we want to just make sure there's enough room for the toe to fit in there and not be rubbing on the top of the shoe. As far as pads are concerned, there are a number of different pads that you can use to try and relieve some of the pressure. This is just a silicone type slip-on pad that can go over the hammer toe to relieve pressure from rubbing on the shoe. The one in the middle here is what we call a crust pad, a little elastic strap that goes over the toe, and then this sits actually underneath the ball of the foot. And that actually, when you step down on your foot with that on, it actually straightens the toe out or holds it in a straight position so it's not contracted. It's not going to correct the position of the toe, but it will hold it in a corrected position while you're wearing it. And then the last one here is just a little sulcus pad or a spacer, foam spacer that's put in between the toes to kind of help the toes from rubbing against each other. As far as surgical corrections go for hammer toe deformities, again, there's a number of different categories or different subtypes of procedures that are done. Capsulotomy is basically releasing the joint capsule to allow the release of the contracture of the toe. It's a soft tissue procedure to let the toe sit down in the position that it's supposed to be in. Tenotomy is a procedure that's done just to release the tendon, to allow the toe to release the contracture and let it sit down in the position that it should be in. An arthroplasty, which is basically cleaning up and repositioning the joint, and this is typically done at the proximal interphalangeal joint, and I'll show you that here in a slide in just a second, to allow the joint to function in a better position. And then finally arthrodesis, which is actually fusing of the joint. And typically with most moderate to severe hammer toe deformities, we're doing a combination of all of these procedures, capsulotomy, the tenotomy, and then either the arthroplasty or arthrodesis. This is just a preoperative view or x-ray of a patient with a hammer toe deformity. On the right here, the anterior posterior, the dorsal plantar view, you can't really see much of the deformity because it's straight in the sagittal plane. It's mostly a straight up and down deformity. But if you look on the lateral view over here, you can see how the second toe is kind of contracted up here and not laying down flat like the rest of the toes are. Actually, just backing up, this patient had both a bunion deformity and a hammer toe deformity. And so, again, you can see this one actually has quite a severe bunion deformity where you can see that the big toe is actually crossing underneath the second toe, and the second toe is being contracted up in the air. This is just an indelible marking pen that we use to kind of mark out our incision, where we're going to place our incision preoperatively on the patient. This is just an intraoperative view again. A smaller blade used on a sagittal saw, and actually what we're doing here is just removing a little bit of the cartilage and bone around this would be the proximal interphalangeal joint of the second toe. So each one of the toes has 3 little bones in it, and there's one here, and one here, and then this would be the metatarsal head back here. That would be kind of like at the ball of the foot back here. So right at this would be like the web space of the toe right here, and then there's 1, 2, 3 bones up in the toe, and you can see kind of the toenail would be right here, toenail here on the third toe. So each one of the toes has 2 joints with 3 bones in it, except for the big toe that has 2 bones and 1 joint in it. And for this correction of this hammer toe, we're using a relatively new fixation device that we've been using for the last couple years now, called Smart Toe implant. And it actually looks like this right here. It's got actually prongs on it that actually go into the bone, and then they spread out once they're in the bone and hold the joint in the position that we want it to be in to allow it to fuse. And this is just a little brooch that's actually going in there to kind of ream out the medullary canal of the bone to allow that implant to be put in place. And this is just a handheld instrument that's being used to push the implant into the bone at the joint. And then this is just the closure of the skin afterwards. Now, along with this, we've already released the joint capsule. We've lengthened the tendon to the toe, and then we've done the arthrodesis, or the fusion of the proximal interphalangeal joint with the Smart Toe implant. And this is what it would look like post-operatively. And that's what that implant looks like. You can see the little prongs here. That goes up into the bone here. The joint would actually be right about at this level right here. And then this part goes back into, this would be the proximal phalanx of the first bone of the second toe. And then this part goes into the middle bone of the second toe. So that joint actually there would be fused, but that would hold the second toe in the correct anatomical position. And we've released the joint capsule back here to bring it down. You can see now here on the lateral view how it's sitting down. This is the second toe right here. There's the implant. You can kind of see it right here, how nice and flush it's sitting down now at this point. On this patient, because they had such a severe bunion, we actually did a procedure back here at the base of the first metatarsal. This is called a lapidus, or an arthrodesis of the first metatarsal cuneiform joint, and we actually used 2 screws across there, crossing them in an X fashion like this. Unfortunately, when we do bunion correction like this on a patient, then they do have to be non-weight bearing in some type of immobilization, a cast, and on crutches for about 6 weeks, because there's a lot of stress that goes across that joint, and we can't allow them to walk on it until that's healed. For just the hammer toe correction, we'll put patients in a surgical shoe, just like this, allow them to walk on their heel, and with the Smart Toe implants, we're getting them back into their normal shoe gear in about 3 to 4 weeks. And then the fourth topic that I wanted to cover tonight is heel pain. Heel pain, probably by far the most common condition that we see in our clinic on a daily basis. On an average day, a full clinical day, I'll probably see anywhere from 20 to 25 patients, and I would say probably close to 5 of them will be heel pain patients on an average day. It's a very, very common problem, affects many, many people, and there is a lot of different types of treatment for it, both conservatively and surgically. As far as conservative treatment goes for heel pain, rest, obviously, trying to get off. One thing I always explain to patients that come in with heel pain, I say, heel pain is most commonly due to a condition, what's called plantar fasciitis. And that's inflammation of the plantar fascial band, which is a tendinous type structure that runs across the bottom of the foot from the heel up into the ball of the foot. And I tell patients, With this condition, the problem is every step you take, you're re-aggravating the problem. And if you have, I try to relate it to having tendonitis in your elbow. I say, if you had tendonitis in your elbow, would you go out and play tennis for 8 hours every day? And patients will say, well, no, I wouldn't. And you wouldn't expect it to get any better. But it's the same thing what you're doing just walking around your house or doing your daily activities when you have plantar fasciitis or heel pain. Every step you take, you're re-aggravating that plantar fascial band. And so that's typically why it doesn't get better as quickly as we would like it to, because short of being completely non-weight bearing, in a cast or on crutches or in a wheelchair, you really can't rest the plantar fascial band, because every step you take, you're re-aggravating it. And I try really hard to explain that to patients so they understand why it's one of the conditions that takes a long time to get better. In most instances, that's the case. Also, ice will help. It's an inflammatory process. We want to try and get the inflammation down, so icing it will help. There's a number of stretching exercises that you can do that will help. We have a sheet that we've developed in our office of the most common stretching exercises that we've found to be very successful with treating heel pain and plantar fasciitis. A lot of times we'll initiate physical therapy. There's a number of different modalities, ultrasound, ionophoresis, TENS units, and things that physical therapy can use to help with heel pain. Again, non-steroidal anti-inflammatory drugs to try and reduce the inflammation. If we try those and those don't work, a lot of times we'll recommend a steroid injection. Of all the conditions we see, I would say that heel pain and plantar fasciitis is probably one of the most common sites that I inject in my office, because it does usually give the patient a lot of relief in a short period of time. And the downside of it is it's somewhat painful to do. So I usually don't offer that on a patient's first visit in my office if I want them to come back, but it is something that usually does help quite a bit. Then over-the-counter arch supports, we usually will recommend the patient get some type of arch support. I would take a look at their shoes. Shoes are listed on here. Again, a good supportive shoe. Orthotics are a long-term solution to the problem. They get them into an orthotic to control the motion that their foot goes through, or the biomechanics that their foot has, to take the tension off that plantar fascial band and to keep it from continuing to reoccur. And then finally, if all of that fails, we may go to immobilization, cast them or put them on crutches to just completely rest it. This is just a couple of the more common stretching exercises. One is you can stand, lean against a wall, drop your heel off a stair. Basically, you're trying to stretch out the Achilles tendon and the plantar fascial band. A lot of times we'll do a lot of soft tissue massage. Rolling a ball underneath the arch of your foot will help with that. As far as injections go, we typically use some type of a local anesthetic. This is 0.5% Marcaine and a corticosteroid. There's a number of different types of corticosteroids. Some work really well on some patients and some don't. So sometimes if I've given a patient an injection and they've gotten some relief or not total relief, we may repeat it with a different type of corticosteroid. This is just Depomedrol here, which is one of the more common ones that we use. We talked about over-the-counter arch supports. This is just an example of those. 3 different types here that we typically recommend for patients to try. Relatively inexpensive and a good first-line treatment if the patient doesn't have good support in their shoes at the time they come in. We'll recommend that they try that. Again, the custom-made orthotics, that would be the more of a long-term solution to the problem. Again, it's going to control the motion that the foot goes through. Not only is it going to support the arch, but it's also going to redistribute the weight evenly across the entire plantar or bottom of the foot, the plantar aspect of the foot, and help with the biomechanics of the foot. Shoes, again, a shoe that's going to have good medial arch support. It's going to have a rigid heel counter. That's really important because that's going to control the motion of the heel, which takes a lot of tension off the plantar fascial band, and something that's both supportive and comfortable. If we do have to immobilize a patient, sometimes we'll use what we call a cam walker or a walking boot, and this is just an example of that. It basically immobilizes the foot and ankle and allows those tissues to rest, even though you can you could still walk, and it's designed to walk. We use this both on patients that are going to be on crutches and patients that are ambulating. I would say that of all the patients that we see in our clinic with heel pain, get better with conservative care. So typically, we're not really recommending surgical corrections for heel pain patients. Now, if I've treated a patient for 6 months or longer and they have not improved in their heel pain, then I'll recommend a possible surgical correction. And of the surgical procedures we're doing, the standard typical procedure done in the past was what's called a plantar fasciotomy. That's a procedure where it's done a number of different ways, but an incision is made in the skin, and basically the plantar fascial band is released or cut to take the tension off of it where it inserts into the bottom of the heel. But more recently now, a new procedure that we're doing is called Topaz, and that's actually, and this is just a picture of the Topaz machine, but it's actually a radio frequency wave that's sent into the foot through a probe, which is shown here at the right, causing basically tissue damage. Basically, when we're trying to cause the plantar fascia to heal, we got to cause some type of trauma to it to provoke your own body's immune system to send reparative cells to that area to correct the problem. And that's done through this radio frequency wave called the Topaz machine. And this is a non-invasive procedure from the standpoint that there's no incision that's made in the skin. All that's done is a grid is mapped out over the most painful area of the heel preoperatively. Again, just using an indelible marker, we mark out this grid pattern like this on the heel over the area where it's painful. And then using that probe, we actually take a pin or a K-wire and actually just poke or punch just a tiny little hole in the skin, and then that probe is inserted into each one of those holes, and that radio frequency wave is sent into the plantar fascial band. So there's no incision, there's nothing that's open. Those tiny little holes are sealed usually within 24 to 48 hours. There's no stitches. And then typically we'll put the patient in the cam walker. We'll allow them to bear weight on it. After the procedure, sometimes we might have them on crutches just for a few days to just keep total weight off of it. But then we gradually progress them into weight bearing from the cam walker back into their regular shoe gear. And again, it's roughly about 4 weeks or so that we're getting back into shoes with this type of procedure. Just wanted to mention some of the products that I showed, especially with the heel pain, the over-the-counter arch supports, the pads and stuff. What we've found over the years that we've been in practice, there's a number of products that we found tend to work very well, and others that don't work as well. And so over the years we've decided to stock a number of those products in a retail store that we have next to our office in Watertown. It's called Doctor's Foot Source. Over the years, insurance plans have changed, as you're all well aware. Reimbursement and coverage for products like ankle braces and foot pads and topical foot medication and things like that are very rarely covered nowadays. Those are all kind of considered durable medical goods. And there's very few of those that are covered. There are, like the cam walkers that I showed, those are typically covered, but just about everything else is not. So we basically have stocked those in a retail store next to our main office in Watertown. And so we'll, if I get a patient in that has heel pain, they haven't tried any kind of arch support, what we found is if you typically go to the corner drugstore or some of the big chains, Walmart, Shopko, or whatever, the products they have typically are something that they've just contracted with a company for. And we found a lot of patients come in and have tried a number of those products, and we just felt the quality of them was inferior. And so we did, over the years, have found what we found tends to work better and seems to be a more quality product and holds up and lasts longer. So we have those in the retail store in Watertown called Doctor's Foot Source. And we also have a website, rrfac.com, Rock River Foot and Ankle Clinic.com. We're updating it as we speak to allow patients to get on there and to at some point probably make appointments through there, but they can also find out more information about our office staff, our locations, our hours. So more and more people are becoming comfortable with the internet. It allows you to, just another avenue to find what services we do provide. And those are my two fishing buddies, Raz and Sophie. Good. Well, I appreciate your attendance and your attention here tonight, and hope you enjoyed it and got something useful out of it. Thanks.